Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. Welcome to Cardiology Rotations Manual, and I will tell you how you can get a free copy of this manual at the end of this presentation. The feature presentation is going to be on cardiac emergencies, first one of which will be STEMI. And if you look at the table of contents, we have more than 150 pages of chock-full information for you to get a better experience on your cardiology rotation. So we cover most of the major topics. Today we're going to move on to the acute cardiac emergencies. Some of the cardiac emergencies that you may face or may not face during your rotation as a student, resident, or as a fellow include STEMI and its complications, which invariably you're going to come across a few of these cases. VT, VFib, certainly you're going to come across these cases, especially if you're carrying the code beeper. Cardiogenic shock is something that you're going to come across if you're in the intensive care unit or in the post-cardiac surgery unit where patients have severe heart failure, who are on LVAD, or patients with extremely compromised cardiac function due to extensive myocardial infarction. Pericardial tamponade is not a very common occurrence. Small pericardial effusions, moderate pericardial effusions are very common. Maybe as a cardiology fellow, you may see 1 or 2 or 3 cases of pericardial tamponade in a medium size. I'm talking about like 200, 300, 400 bed hospital, unless you're in a major medical center where you can have a huge number of cases. Acute limb ischemia is an important thing to be considered, especially if the patient has a cold cyanotic limb and if they have any evidence of embolic phenomenon, then that's something that needs emergency attention. That's something we're going to cover in a different video. Acute pulmonary edema can happen in patients walking from outside the hospital to the emergency room, or it can happen inside the hospital after the patients have been in the hospital for a few days, and all of a sudden they wake up in the middle of the night with acute pulmonary edema, and you should be able to recognize is this cardiac and how you deal with those. And of course, the post-procedure bleeding, chest pain, arrhythmias, these are all things that you're going to be called on in the middle of the night. So don't ignore the calls when you get it, because otherwise next day they're going to write you up and you'll be getting a call from your chief of department. Atrial fibrillation with rapid ventricular response, like heart rate of 200, 220, then you have to decide what to do. First, there are some general stuff. You need to have a thorough understanding of what has transpired in this patient's cardiovascular history in the past. The best place to start would be to look at their electronic health records, make a complete summary of their entire cardiovascular history, tests, medications, allergies, blood thinners, and all these things are important. And also, you examine the patient. How is the patient? Can the patient lie down flat? Can the patient talk to you? Is the patient extremely in pain? Is the patient having shortness of breath? Is the patient profusely sweating? These are things which will help you to get a better assessment of what's happening with the patient. Of course, you order the routine lab test like CBC to look for any evidence of bleeding or infection, electrolytes, magnesium, potassium if you're dealing with arrhythmias, and of course you look for the electrocardiogram to look for any evidence of arrhythmias, ischemic changes, heart blocks, if somebody is having a severe bradycardia. And an echocardiogram may be one of the most useful diagnostic tests if it's available. Obviously, in the nights and down weekends, it may take a while to get the echocardiogram, but nonetheless, they will be useful. But we can certainly get a chest x-ray to rule out pneumothorax, heart failure, pulmonary edema, or pneumonia, things like that. Okay, let's move on to STEMI. So we're going to, when we are dealing with a patient with STEMI, as a student, as a resident, or even as a first-year fellow, your job is to get as much as information about this patient's clinical condition, because you are the only person who has reviewed the chart. The person who is doing the STEMI procedure has very little time to review the entire chart and be cognizant of how many multi-system problems are there to affect the overall outcomes. Of course, they're going to be asking you, so you need to be prepared to make the presentation. And here's an example of an anteroseptal myocardial infarction with ST elevation and lifting of the T waves with the reciprocal changes in the inferior leads, and at least the heart rate is like 75, which is a good sign, unless if it was like 120, then you would be more concerned. And here I have put together some points mostly like STEMI focused or acute coronary syndrome focused points you need to cover in your summary of the patient's presentation. The risk factors to start with: hypertension, diabetes, smoking, family history of coronary artery disease, lipid medications, allergies, blood thinners. Blood thinners are extremely important. A lot of these patients may be on Coumadin, and if you're taking these patients with Coumadin on board, there is an increased risk of bleeding, but we have to weigh the advantages versus the disadvantages. When was the last time the patient took the medications? Does this patient have coronary artery disease? How many heart attacks does this patient have? When was the last heart attack? How many stents does this patient have? When was the last heart catheterization? What were the cath findings? See, you have to summarize the cath findings. The patient had 80% lesion in the medial AD. The patient has a stent in the proximal LAD. The patient has a stent in the right coronary artery. The distal right coronary artery looks okay. The circumflex trunk has small marginal branches. There is a stent in the circumflex trunk. So you need to tell exactly what this patient has, because when they are doing cardiac catheterization, they're going to ask you, what does the history show? All right. If the patient had bypasses, how many bypasses did he have? Did he have a bypass with a lima? Did he have a saphenous vein graft to the marginals? Was there a PDA graft? Did they use a REMA or the right internal mammary artery? So you have to document all these things. Next thing, if you have time, you may not have time for a STEMI patient, but you may want to get an echocardiogram after they return from the procedure. But you can always look at their electronic health record. Electronic health records are going to be your best friend when you're dealing with cardiovascular patients, because this is a chronic ongoing process. If they have been coming to the same hospital and they're following the same doctor, chances are there's an extensive electronic health record. Review everything related to the heart and make a summary of their cardiac findings, stents, cardiac caths, echocardiograms, EKGs, nuclear stress tests, whatever they had, pacemakers, so that you have a very good understanding of what's happening inside their heart. If the patient had an echocardiogram, when was it done? What was the result? What was the left ventricular size and what was the left ventricular function? Were there any valvular leaks that we need to be concerned about? And when was the last time a patient had a provocative stress test, either stress echocardiography or nuclear stress tests? And what were the results? And most importantly, has this patient been on blood thinners? If they are on dual antiplatelet therapy, they can still be taken to the cardiac catheterization lab. But if they are on warfarin, then we may have to be very careful. If it's a STEMI, I think they're going to go ahead and do it and then address the issue of bleeding later on. Then we need to look at allergies. Did this patient have any allergy to certain drugs that we need to be aware of? Any history of cardiac arrhythmias, atrial fibrillation, ventricular ectopic beats? What medications is the patient getting for cardiac arrhythmias? Does the patient have cardiac pacemaker or an ICD? All these things are important, and this is what the job of the student, resident, and first year fellow is, to get a comprehensive pre-procedure summary. I mean, that's the best way I can tell you, because the more information you have and more easily you're able to communicate to the interventional staff, that's where you're going to score some brownie points and perhaps save a patient's life. Okay, you also have the chance to scrub and go into the cardiac catheterization lab and see a proximally occluded left anterior descending artery, where they can put a wire across that and put a balloon, inflate the plaque, and put a stent. Or you got a totally occluded right coronary artery in an inferior infarct patient. You can see how easily they can get the wire across the thrombus and compress the thrombus and then put a stent. and re-establish the coronary circulation. Now, once they come back from the cardiac intervention procedure to the floor or to the ICU, your job becomes pretty active. That's when you need to be monitoring vital signs. Listen to their cardiac findings. If this patient had an anterior MI, you need to make sure they are not having any murmurs. That will be the baseline. If they develop any new murmurs, then you know you're dealing with some issues. Maybe a papillary muscle dysfunction, maybe a small ventricular septal defect. Then watch for any bleeding. Look at the arterial puncture site and make sure there's good pulse beyond the clamp they use, and make sure the arterial circulation is okay. There's no bleeding. Of course, we want to watch for complications of acute myocardial infarction, which could be heart blocks, bundle branch blocks, ventricular arrhythmias, VT, VFib, or they can develop mitral regurgitation, or they can have a ventricular septal defect from an anteroseptal infarct, or about 20% of them or 30% of them may have right ventricular infarction leading to prolonged hypotension. I mean, let's look at it this way. If somebody is in a cardiogenic shock, the mortality is 80%. If a patient has right ventricular infarction, with persistent hypotension, the hospital mortality could be anywhere from 25 to 30%. We need to monitor the blood thinners. You look for any evidence of hematoma. Regularly monitor their blood counts. Of course, we need to start them on medical treatment. Beta blockers. Make sure their volume status is okay. Then ACE inhibitors and ARBs, which are essential in treating patients with coronary artery disease, hypertension, and especially if they have reduced ejection fraction, like less than 40%. Of course, they all need to be on high intensity statins, aspirin, dual antiplatelet agents, and warfarin if they have concomitant atrial fibrillation. Using triple drugs for anticoagulation is a question which is beyond the scope of this presentation, but initially they may be on 3 medicines for like 30 days or so, and then aspirin may be dropped. Then you just have an antiplatelet agent, and warfarin with the INR being close to 2 rather than 2.5. Of course, we need to monitor their blood pressure and blood sugar, and after discharge, make sure before they leave, you go over each one of these medicines and make sure why they are getting these medications. Emphasize the significance of dual antiplatelet agents. I had a patient who had a stent in the LAD. He went home. He forgot to fill the prescription, but it was a week. So he went almost 1 week without dual antiplatelet agents. Luckily, nothing happened, but you don't want to see that. You don't want the patient to come back with an acute second STEMI because they didn't fill their prescription or they are not taking the dual antiplatelet agents. That is a real concern. That's why we need to call these patients 24 to 48 hours and go through the medications again and see what medicines they are taking, how often they are taking, and if they are skipping any of these medications. Generally, I would like to see them within a week, because I want to make sure that their rhythm and EKG is okay, their groin is okay, if you're going through the groin, or the arm is all right, and they are taking all their medications. So this is a sort of an acute management of a patient with the STEMI. I hope this has been useful to you, and there are a couple of charts here showing algorithms from the ACLS course. If you are in an institution where there is no facility for intervention, the only option you have is using fibrinolytic therapy, and here's a chart which tells you to go through a checklist before you administer fibrinolytic agents. And let me tell you how you can get a copy of this book. Just send me an email to drniknikam@gmail.com, and I'll be happy to send you a copy of this book. Let me know what other information we can add to this manual, which is free. Please do subscribe to our YouTube channel, and I will see you next time. Thank you so much.